Hi guys, we are going to continue our discussion about topical fluoride. Last time we met, we were talking about a lot of the oral health products. We were talking about the different kinds of fluoride, the Stannis fluoride, the sodium monofluorophosphate fluoride, and the different types of active ingredients in the products that we use or we would recommend. We're going to go a little bit more into the science and dosage of the topical fluoride for this lecture. I am using Mrs. Corpola's PowerPoint. I would like to change it after going through it, but I'm going to hit on the high points from the slides that I really think you need to know. For one, we've got to remember the numbers, our critical pH numbers. Critical pH for enamel is 4.5 to 5.5. For cementum, it's 6.0 to 6.7. The enamel is 96% mineralized, hardest structure in the body. So it takes a pretty low pH to start the demineralization process on enamel. Cementum, which is the root surface, if there is root surface exposed, then the pH in the mouth does not have to get very low from the 7.4 normal basic pH to get to a point where it starts demineralizing the root surface. That's why root surface caries are they progress so much faster and they can be so much more rampant. Enamel 4.5 to 5.5, cementum 6.0 to 6.7. You've got to remember those numbers. You're going to see those numbers constantly. Now, we've been talking about preventing demineralization. Our whole BMod project is based on the fact that we want to help a patient control habits and caries risk factors that would lead them to demineralization, lead them to caries, lead them to eventually losing teeth, right? So we want to tell them all about the frequency of sugar. The frequency of sugar, meaning that anytime they eat or drink anything, the plaque bacteria produce acid. The acid demineralizes the teeth because it lowers the pH in the mouth for a certain time period based on the kind of sugar it is, whether it's a liquid sugar or a sticky sugar. We know that it lowers the pH in the mouth and demineralization can occur. If they keep eating or drinking, remember I told you the 20-ounce pop is the worst invention ever because they, 20 minutes later, 20 minutes later, 20 minutes later, all day long, and it's always in a demineralizing state. I know in clinic, quite a few of you guys have probably heard me say, oh, you're a pop drinker, aren't you? You go, oh my God, how does Mrs. Schramm know that? Well, there's just typical smooth surface decay that you see from that demineralization process. It's typically along the gum line where the plaque would sit, where the plaque would produce the acid in a little white line along the gum line. We've got to get patients to get the plaque under control. So the brushing frequency and technique is important. Not a guarantee that they're not going to have big demineralization or caries, but you've got to get that under control. Anytime we can increase their fluoride, so whether that's fluoride toothpaste, prescription fluoride toothpaste, we talked last time about the typical over-the-counter toothpaste being 1,000 to even up to 1,500 parts per million. Then we talked about prescription toothpaste, the Prevident, being 5,000 parts per million. We talked about some of the mouth rinses, or you guys had to do your assignment, where it looked at mouth rinses being between 125 and 250 parts per million. And remember all the little things that I told you for fluoride. For example, if you have a patient who brushes their teeth and they rinse all of that fluoride toothpaste out of their mouth afterwards, then they've just rinsed away a lot of that fluoride therapy that could come and help with remineralization. How about if you just get them to spit out all the toothpaste, as much as they can, and then the fluoride that is left with the toothpaste residue would sit in between the teeth or sit on the teeth and keep that remineralization process going a little bit better. Maybe they rinse out and then they rinse with a fluoride rinse. Maybe they do fluoride trays where they put fluoride in for a certain amount of time and then they don't eat or drink. That's something we can do with a patient at home. restricting their sugar intake and basically their frequency of sugar intake. Sure, we'd like to say no sweets, no candy, but that's not realistic in a lot of people's lives. You know, they go to the vending machine, they go to the pop machine, you know, for an afternoon pick-me-up. And if we can reduce their sugar intake, look at where their sugar sources are coming, and then reduce or limit the sugar intake and let them know the frequency of sugar in the process. And then you guys had to do that great saliva test that we liked so much to take a look at the saliva consistency and the saliva output and how much that has to do with the demineralization, remineralization process, and how saliva is so very protective and important. Now we know that strep mutants start caries. They're gram-positive, they adhere well to the tooth, they produce higher amounts of lactic acid from the sugars, they're able to store some of the glucans from the sugars, and they're able to store them so they can, you know, you ingest the sugar, but then they can kind of hang on to them and eat it a little bit later. There's a high count of strep mutants on smooth surfaces, and the strep mutants decrease in number as teeth are lost. So when they don't have as many places to hide. Lactobacilli, these are the bacteria that are found in larger numbers after the caries has started. So they continue the process. They're involved in later stages of decay. They aren't able to produce the pH to start caries, but they certainly continue the caries process and the demineralization process. Actinomyces are associated with root caries. So you see the caries on this particular picture in the cervical area. Actinomyces are associated with root caries. There is some more recent literature that is showing some strep mutants being related to root caries, but for now, actinomyces are specifically tied to root caries. The remineralization process, we've been talking about this whole semester. You need calcium, you need phosphate, you need fluoride. We need to make a more perfect tooth crystal. We have the hydroxyapatite tooth crystal. When there's demineralization process and there is calcium and phosphate and fluoride that are floating in your saliva, during the remineralization process, the tooth uptakes those, I was going to say chemicals, but they're not chemicals, those ions, those minerals back into the tooth structure. If it takes fluoride back into that tooth structure, then it makes a more perfect tooth crystal. So it's a fluoroapatite crystal. Fluoride can be in the saliva, fluoride can be in the plaque. If we are putting fluoride varnish, say, on a tooth, say we go into a school and we're doing a fluoride varnish program, we're not getting the kids to necessarily brush. That plaque that sits at the gum line is going to uptake and hold some of that fluoride against the tooth surface. There are fluoride prescriptions, fluoride Prevident 5,000 parts per million toothpaste, prescription toothpaste, over-the-counter rinses, toothpaste, and some of our Recaldent or Myiasis products that have calcium and phosphate in them that are helpful for the remineralization process. Remember our GB Black. This is something that you will definitely see on boards, definitely see on quizzes and tests along the way. We've got class 1, our occlusal and buccal lingual pits. Our class 2 is our posterior interproximal. Our class 3 is our anterior interproximal. Class 4 is our anterior interproximal involving the incisal edge. Class 5 is that buccal, cervical, lingual area right at the cervical. And then class 6 is our cusp tips. So every time we review this, this is something where you're like, yep, 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 oh, forgot that one, yep. The mechanisms of action of fluoride, they promote the remineralization process. We want frequent low concentrations. That is more beneficial than if we just got high concentrations infrequently. So it's not enough for a child or a person to come to the dentist and get a fluoride treatment every 6 months. We want systemic fluoride before teeth are developed. small amounts of systemic fluoride, and then frequent low concentrations of topical fluoride throughout their life. That's the biggest benefit. Makes the tooth more acid resistant, and it lowers that critical pH. Fluoroapatite makes the tooth stronger, makes a more perfect tooth crystal. It's more acid resistant than our enamel structure of hydroxyapatite. Fluoride is bactericidal and bacteriostatic. It has substantivity. It does what it's supposed to do, and it stays where it's supposed to stay. It doesn't have a need for us to remove the plaque or the pellicle. It stays, and its mechanism of action works in the area due to the substantivity. And it accelerates the maturation of newly erupted permanent dentition. So it helps strengthen those permanent teeth. So systemic, we get the benefit from pre-eruptive fluoride. So water can be considered topical as it passes over the tooth, but it can also be considered systemic as it's going into the body, and as the teeth are mineralizing before eruption, it's systemic. Water, anything swallowed containing fluoride prior to crown formation, any fluoride supplements, any food that has fluoride. We talked about fluoride sources, where there's a lot more fluoride sources. We talked about tea, we talked about grapes, we talked about the chicken nuggets, all having sources of fluoride in them. We talked about canned vegetables or fruits that are canned in plants where there is water fluoridation being used for the water that is going into those canned vegetables. So there's a lot of different places that people are getting fluoride. Once it's post-eruptive, it's water in the topical form versus systemic form. It's toothpaste, it's rinses, it's gels, it's every 6 months the fluoride treatment. Systemically, fluoride circulates in the bloodstream. It's incorporated into the developing enamel as the teeth are formed. We'll talk a lot more about that in histology, the formation of the tooth. It is absorbed in the stomach and small intestines. It is retained in the body, and it's stored in the bones, and there's a small amount in the teeth. It's effective from the 6-month time period to the 14-year time period. 6 months is when our permanent incisors are forming, and we'll talk all about the tooth formation and when that's happening. And 14 years is when our third molars would be finishing with enamel formation. And fluoride is excreted through kidneys. So it's absorbed in the stomach and small intestine, and it's excreted through our kidneys. Water fluoridation, there is adjustment of the fluoride ion in the water supply. It's very cost effective and efficient for a community. The larger the community, the lower the cost, and the optimum level is 0.07 parts per million. Used to be 1 part per million. Used to be 1.2 if you lived in a colder climate, because it was assuming you wouldn't drink as much water. So they had it at a higher level in a colder climate, and they had it in a lower level, 0.07 parts per million, in a warmer climate, assuming that you would drink more water so you would get more benefit from the fluoride. There was a study of 12 to 15-year-olds, I believe it was in 2012, that showed that there was some fluorosis that was showing up on 12 to 15-year-olds based on all the different sources that there are for fluoridation. So they lowered that to 0.07 parts per million across the board, not taking into account warmer or colder climate. Fluoride, when they do water fluoridation, they use fluorspar, sodium fluoride, sodium silicofluoride, hydrofluorosilicic acid, and it's very closely monitored. A lot of people will say, well, they don't have fluoridation in Europe, look at them. Well, Europeans are typically known for a lot of caries, and there are a lot of different sources of water, a lot of different places where people get their water in Europe, and it would be very costly to go after all of those small areas to fluoridate water on a public level or community level. Water fluoridation acts as topical, and it works on the smooth tooth surface the best. Fluoride is the most effective on smooth surfaces, and then sealant programs are going to be the most effective on the occlusal surface. And I believe I've given you these numbers before, but if I haven't, with a sealant program, after 1 year, the sealants are still 85% effective if they're intact. At a 5-year mark, they have a 50% effectiveness rate. And the goal would be is to get children to adulthood with the occlusal pits and fissures of their teeth protected. We want to get them through their cavity-prone years. If sealants are done well, and they're very technique sensitive, so if they're kept dry and done well and they're intact, they are a great device product to use to prevent caries. Fluoride supplements are given for pre-eruptive purposes. Fluoride supplements are for children only. So these are children who are still developing the teeth systemically. The crowns of the teeth are still developing. So they're not going to do anything on a tooth that's already erupted. In this chart, this dosage schedule, this has been the same schedule. Birth to 6 months, no fluoride is recommended. 6 months to 3 years, 0.25 milligrams a day if their drinking water is less than 0.3 parts per million. From 0.3 to 0.6 parts per million or over 6 parts per million, from 6 months to 3 years, there's none recommended, no additional fluoride supplement recommended. For a 3 to 6 year old, if fluoride is less than 0.3 parts per million, they recommend 0.5 milligrams per day. If it's 0.3 to 0.6 parts per million, they recommend a supplement of 0.25 milligrams per day. If it's over 0.6 parts per million, none. 6 to 16 years old, if it's less than 0.3 parts per million, they recommend 1 milligram per day. If it's 0.3 to 0.6 parts per million, they recommend 0.5 milligrams per day. If their water is over 0.6 parts per million, when you add all the additional sources that a child would potentially get, there is no supplements recommended. And these milligrams don't equate to the parts per million. So like when they say 6 to 16-year-olds on this chart, if it's less than 0.3 parts per million, 1 milligram a day, that doesn't mean 1 milligram plus 0.3 is 1.3 parts per million. That would get them to the optimum level. So we've got our professionally applied sodium fluoride gel, which is a 2% sodium fluoride gel, 9,050 parts per million, used when a patient has tooth-colored restoration. So this is our neutral, used when patients has tooth-colored restorations or sealants, or orthodontic patients who have a glass-filled cement. We'll talk about cements and that kind of thing in the summer in dental materials. Chemotherapy patients and dental implant patients, we would use the neutral sodium fluoride gel. 2% neutral sodium fluoride, 9,050 parts per million. When in doubt, use the neutral. You'd put it in the tray for 4 minutes versus 1 minute. No eating, drinking, or smoking for 30 minutes afterwards. And remember, this is a good refresher for the fluoride instructions that you're supposed to give your patients. Sodium fluoride varnish. This is our 5%. This is the varnish, the paint-on varnish. 22,600 parts per million. There's Duraflor, Durafat. There's lots more brand names versus the first couple that came out. Desensitizes root surfaces. Off-label use is for caries prevention. So off-label use for fluoride varnish for caries prevention. It was originally approved for desensitization. 0.3 to 0.5 milliliters in the application. It can stay on the teeth for up to 24 to 48 hours. Repeat at 3 to 4 month intervals. And it's more effective than others due to the longer contact time on the teeth. Remember, the directions for this are that we want the fluoride to stay on the teeth for 4 to 6 hours. They can brush at bedtime, because typically the appointments that we have, there would be 4 to 6 hours between their appointment and bedtime. The longer the better. If they brush it off before, then it's just going to be less effective. And for this one, nothing hot, crunchy, sticky, no alcohol, and of course no smoking. We always want to add that in when we can. This is not something you're going to use at home. We're going to apply this. Then we've got our Stannis fluoride, which is a rinse that is mixed. This one isn't used a lot, but it's an 8% Stannis fluoride, 19,360 parts per million, so a good fluoride concentration. It doesn't taste great. It stains in some of those demineralization, demineralized areas, and it can cause some sloughing of the gingival tissue and some discoloration of tooth-colored restorations. So, okay, great, it's, you know, a higher concentration parts per million, but you have to mix it. Doesn't taste good, and it stains. Ugh. This one I haven't seen in a long time. Doesn't mean because I haven't seen it that it's not out there. The acidulated phosphate fluoride, this is the one that's the 1.23%, 12,300 parts per million. It will etch any glass components in tooth-colored restorations or sealants or porcelain, so we do not want to use it on composites, tooth-colored restorations, sealants, or porcelain. In a tray, we would put 2.5 milliliters for adults. It can be a thick gel, thixotropic, so a thicker gel, or it can be a foam. It's not as effective as a regular low concentration on a daily basis for a patient, but this one, because of the acid, it will etch the surface, and the tooth has a better uptake of this particular kind of fluoride if it is on the right patient. That right patient would be no sealants, no composites, no porcelain. So it's a good fluoride, and there's good uptake and good results with the APF. But when in doubt, you're going to use that neutral sodium fluoride 2% gel or foam, or you're going to use the 5% sodium varnish, sodium fluoride varnish. And remember, we talked in preclinic about the gel being proven and, you know, having good research, and the foam not being as effective. It's been found to not be as effective. So keep that in mind. Here's the different concentrations of the fluoride, and this is the 2% neutral gel or foam, the 1.23% acidulated phosphate. This is the one that etches the surface, so we want to not use it on the porcelain composite or sealants or glass ionomers. And then the 8% Stannis, which is the one we talked about, stains. Stannis has always had that reputation for staining and for sloughing of the gingival tissue. For the sodium fluoride, we can use it up to 4 times per year for the 2%. And then for the acidulated phosphate, 1 or 2 times per year. And for the Stannis fluoride, 1 or 2 times per year. Topical fluoride, patients can have a tray that they take home. They can use a rinse. They can use toothpaste. They can have a prescription toothpaste. They can have prescription gel that they use at home. So there's all different kinds of sources that they can get at home, or we can recommend, or we can give them prescriptions, have the dentist give them prescriptions for. No rinses for patients under 6 years old. And for 4 to 6 year olds, they should have toothpaste with supervision. They should have just a pea or a rice size grain of, grain of rice, that little bit of amount of toothpaste that has fluoride in it. Professional treatment is it's not recommended for under age 3. And we need to try to use fluoride varnish on the 3 to 6 year olds, on elderly, on handicapped, and diabetics. Diabetics so they can eat right away. Handicapped and elderly and 3 to 6 year olds, it stays on the surface and they will get better length of contact with that fluoride. And I have a list here of our fluoride doses. Hang on 1 second as I find this. So there are some lethal doses of fluoride. So there's some safely tolerated doses, and then there's, lethal doses. We want to use, whatever we're doing, we want to use the minimal amount that will do the job that it needs to do. I'm talking about that with the second-year students with local anesthesia. If we can use a lower amount or a half a carpule of anesthetic, why would we use a whole one? If we can fill an arch, a fluoride foam tray, maxillary mandibular arch, if we can fill them, why would we need to overflow them? More is not necessarily better for the things that we use. So for the fluoride lethal doses for an adult, it's 5 to 10 grams. For a child, it's 0.5 to 1 gram. When patients have a fluoride overdose, it's going to typically feel like they've got flu symptoms. They are going to have some nausea. They're going to have vomiting. They're going to have diarrhea, abdominal pain. They're going to have increased salivation and thirst. The one thing, let me see what's on the next slide here, is if it's acute, it's going to be within 30 minutes of ingestion. It's going to last maybe 24 hours, and it's just going to feel like you've got a bellyache. We want to recommend that if they get that stomach ache, if they get that tummy ache, that they have something with calcium. So we talked about that in preclinic. Have some milk, have some cheese, have some yogurt, and that will bind with the calcium. That would be a more acute toxicity. Once absorbed, I think about the 3 C's. And if we were in class, I would write down 3 C's. The C's are coma, convulsion, cardiac arrhythmias. The calcium binds fluoride, causing nausea, stomach pain, increased thirst, and salivation. That's the initial. But then the 3 C's combine and can take a person on a systemic level to coma, convulsion, or cardiac arrhythmias, cardiac failure, respiratory paralysis. You want to induce vomiting, administer something that's going to bind with that fluoride, so anything with calcium in it, calcium chewable tablets like Tums, or milk of magnesia, liquid and acid will work. Less than 5 milligrams, administer the fluoride binding agents. Greater than 5 milligrams could be a toxic dose. Remember, the adult toxic dose is 5 to 10 grams. So you'd induce vomiting, administer fluoride binding agent, and seek medical treatment if you knew that it was over 5 milligrams. If it was greater than 15 milligrams, that is a lethal dose for sure in a child, because 0.5 to 1 is the child lethal dose. And the smaller the child, the lower that dose is. For an adult, it's 5 to 10. So first thing you would do if they got over 15 milligrams is seek medical treatment, induce vomiting, and monitor for cardiac problems, for the coma, convulsion, or cardiac arrhythmias. Topical fluoride has been shown to, and I won't say topical, more the combination of topical and systemic. If a child has chronic overexposure pre-eruption, then there will be evidence of fluorosis. We don't know to what degree, because we don't know how much extra fluoride was incorporated into the tooth structure that may have altered the way that the ameloblasts were forming enamel on that tooth structure. There is a combination of all of the sources ingested. So if somebody wasn't taking an additional systemic additive, additional fluoride in the form of a pill or a drop or something like that, there's a lot of different sources. They could have hypomineralization, so the ameloblasts have been disturbed by the fluoride, and there's low mineralization, there's stained mineralization, there's pitted or mottling on the teeth, and this will occur all the way up until the time that all of the crowns of the teeth are complete. If you consider the third molars, that can be up till age 16. The crown of the tooth forms first and then the root forms. And for aesthetics, when you're looking at the anterior teeth, up to about age 8, because 8, 9 years old, those teeth are erupting and the crown of those teeth are formed. If there is fluoride fluorosis evidence, typically you will see it on all the teeth that were forming at that same time. Let me look and make sure I don't have anything else for you. I think we're good. I'm going to do the Zoom lecture tomorrow, and I'm going to be lecturing over this, and I'll see if you guys have questions. And then I have 2 assignments for you to fill out that go along with this lecture. So I will see you online tomorrow. Good job, guys. Good job.